afternoon, everybody. I was trying to show off, and whenever you try to show off, it always comes back to bite you. I am getting older and not quite as nimble as I used to be. But anyway, I am Tim Zemer. I am privileged to be the coordinator for the President's Malaria Initiative. I think most of you in this room are either partners, supporters, or colleagues, and it's good to see so many familiar faces. I feel fortunate to have been invited to say a few words to you and to this workshop as we acknowledge some of our key partners and then share information, lessons learned, best practices, and what didn't fall into the best practice area that we can put on the table and consider so that our output and our impact on behalf of the country and the constituents that we serve will be improved. I had some prepared remarks, and when I walked in here and looked at the audience, I decided to keep my prepared remarks in my pocket, and if you'll allow me to just make a few personal comments, I'd appreciate it. And then, regretfully, I have to leave. I have an out-of-town guest that's here, and I have to go over and kick off another meeting. First of all, as I look over this room, I want to express my personal thanks to each of you. Even though I don't know you, I know that you're here because you're committed to an organization, a country, and a cause. Public health, probably malaria, or an organization or a mechanism that supports malaria and health in a specific place or country or region. I didn't begin my life as a public health specialist. After I finished university, I started my career flying airplanes for the United States Navy. That was pretty exciting. I learned as a pilot, it was my job to look for hostile airborne targets as well as hostile targets on the ground. I find a lot of comfort in my job today because one of our targets is a very hostile airborne target. It's called a mosquito. And I tell many of my audience friends here in the United States that my job is to take on one of the most dangerous animals in the world. And everybody holds their breath, and I say it's the mosquito. And all of you in this room understand the adverse impact of that insect and the carnage that it carries to our communities, our villages, and our families, and those that we love so much. And so as we spend time together today to look at programmatic work, the past, what we're doing together as partners, and positioning ourselves for the future, there isn't anything more important than we can do. Let me put my program hat on for just a minute. Over the last 5 years, the United States government, through the President's Malaria Program, has been fortunate to see and participate in the very encouraging trends that we see reported by WHO, specifically with the countries in sub-Saharan Africa. When you look at the reductions in the morbidity and the mortality rates, when you look at the reductions in parasitemia in some of the districts and provinces, when you look at the rates of improvement of positive diagnosis that's happening from 5% in 2000 to as high as 45% in 2010, diagnosing people with fevers so that we can get them treated with effective ACTs, that's encouraging. We're all optimistic about those trends, but all of us are holding our breath about the future. I spend most of my time today talking about the successes that you produce as partners with the U.S. government in the field to my colleagues up on Capitol Hill. Our Congress knows the President's Malaria Initiative program very well. They consider it one of the most effective U.S. government foreign assistance programs. The last time I went up to a hearing as part of a public health meeting, they ran out of time. And so I didn't get a chance to make my comments. And as I got ready to go, I asked if they wanted me to come back. And one of the staffers said, "No, we know the malaria program. You're doing okay. We won't need you to come back." Now, that's a nice compliment, but I would like to reverse that and turn that around to you, supporting partners here in D.C., our staff at USAID, CDC, and in the country, but more importantly, to the front two rows over here to my left, the partners in the field that have come to represent the significant impact that our NGO partners are having on behalf of the country programs. If you look in our annual report, you'll notice statistic that the PMI program has over 220 NGO partners, of which about a third of those are faith-based partners. After I left the Navy, I was privileged to run World Relief, which was a faith-based NGO out of Baltimore. We were in 26 countries. And that's when I got my training wheels on the significance of NGOs and the faith-based organizations in terms of their impact as partners, assisting countries and communities in their fight against different causes. There's no doubt in my mind that without a strong commitment to the private partners, NGOs, the U.S. government programs would not be as strong as they are today. And so I just want to communicate that this administration, our President Obama, Secretary of State Clinton, Dr. Raj Shah, the Director of Foreign Assistance, all acknowledge and embrace the role of the private sector as well as the private partners, NGOs, in the field in order to have high impact and make our dollars go further and to be more successful in achieving country goals. So as you go through your discussion in this workshop and communicate lessons learned, best practices, some of the practices that were not so good, I want you to be very honest so that as we have an opportunity to share, we can look at building better programs in the future. And the U.S. government, USAID, and the President's Malaria Initiative is committed to continue to develop business plans through our USAID missions to support country plans and leverage other donors' contributions so that we all come together with a single plan, chasing and moving out towards common goals on behalf of the beneficiaries and the people in the communities. That is not just rhetoric, it's a goal and a commitment that is shared above me, and I'm really pleased to be able to communicate that on behalf of our national leadership. One other thing, I do want to plug our U.S. Congress. Right now, they do not enjoy a very high rating in terms of reputation and success. But our Congress is strongly behind global health and have been significant supporters of the President's Malaria Initiative. And every chance I get, I do acknowledge the bipartisan support and the appropriations and the dollars that they send our way to support our commitment to fighting malaria around the world, specifically in sub-Saharan Africa. So, those are my personal remarks. Again, I want to thank our partners, primarily those in the front two rows. Thank you for your work, the efforts, and the impact that you're having. And for those of us in the rest of the room, I look forward to continuing to work with you as partners, as suppliers, so that as we continue to work towards our targets and goals, that we will continue to show measurable impact in all that we do. So thanks for allowing me a few minutes to share a few personal thoughts. Have a good rest of the panel, and I look forward to hearing from my team on what you all discussed. And I promise to follow through on any action that you pass along. Okay, have a good afternoon. Thanks.
Thanks to Admiral Zimmer for that great introduction, and thanks to all of you for joining this afternoon. I'm Deborah Prasnitz from MCHIP, one of the technical advisors to the Malaria Communities Program, along with Alona, who's here in the front row. And today we have 7 representatives of grantees of PMI's Malaria Communities Program, as well as some PMI staff, and I'm going to let everybody go ahead and introduce themselves.
My name is Evaristo Waya, and I am the Programming Officer for ADPP Angola.
I am Macpherson Kapalamula, the Project Director for Malaria Communities Project concerning Veso, Malawi.
My name is Roland Swami. I'm the Program Director for Equip Liberia.
I'm Dr. Patrick Hukelo, the Program Manager for Malaria Communities Project, Medical Teams International, Uganda.
Good afternoon. My name is Charles Zangira. I'm the Project Director, Health Right International, Kenya.
Good afternoon. My name is Deusdedit Mjungu. I am the Project Director for Malaria Communities Program, which is implemented by Christian Social Services Commission from Tanzania.
Good afternoon. My name is Ambesutola Feisa from Ethiopia, FAIA Integrated Development Organization, Director of the organization. Thank you.
Hello, my name is Megan Fotheringham, and I am on the MCP management team for USAID PMI.
Hi, I'm Susan Newell. I'm also with the Malaria Communities Program management team at USAID Washington and the President's Malaria Initiative.
Okay, well, thanks, everyone. And as Admiral Zimmer alluded, we're actually here just to have a discussion. So we have a number of questions, and we'll just engage in a discussion amongst folks here. So I'm going to start off with the first question, and just raise your hand, and we'll pass the mic to you, and you can respond, okay? Okay. ITN ownership has increased dramatically since the inception of PMI, but consistent and correct ITN use continues to be a challenge. How have your projects addressed this, and how have you fostered community ownership or responsibility around care and use of ITNs?
Thank you very much. I think it's really true that in terms of ITN promotion within the projects, the use and the consistent use, I think, has been a challenge. But as a project that's concerning Veso Malawi, we realize that before we do any promotion campaign, people have to be aware of the product, that's the net itself, and how it's going to be used. So through mass awareness campaigns, which were coupled with theater for development dramas, but also actual net demonstration on how the households could use the nets, that strengthened the ability and also the capacity of the households to be able to use the nets. But also through the community structures which we have been trained on malaria promotion, the community structures or the community volunteers has been visiting the households just to ensure that they have properly hung the nets, but also they are using the nets as per advised. But also as a project, we have been doing the post-net distribution surveys, which we usually do every 6 months after distribution, but also 18 months after distribution. In terms of this post-net distribution survey, we are trying to make a follow-up to the households which have managed to receive the nets to see if the nets are available, in what condition are the nets, and also have a spot check on the net hanging, if the nets can be in the house but not being hanged properly. So these are some of the initiatives we have been trying to promote within the committees so that they are able to follow up and able to document that the nets are being used properly, correctly, all day throughout the year. Thank you.
Okay, thank you. I would like to start saying that our MCP projects in Angola were implemented in the province where there were no mosquito nets. We have started our projects by doing baseline stats. That shows that it's not because people didn't want to use mosquito nets, but they were not available in the communities. So we are using the school base as a philosophy of the projects where we train teachers and the students in the schools. So during the period of the projects, also we had good cooperation with Mentor, who has distributed mosquito net in the communities. And then we had a project about behavior, communication for behavior change. So the students, they went to house to us to see how people they are using the mosquito nets, if they are using in the correct way. Because as they didn't use before, it was very necessary that to teach them to use correctly the mosquito nets. And then we have formed groups in the communities who can follow up on 2 weeks basis to check whether the families they are using the mosquito net.
Okay. In addition to partnerships with local district ministries of health and facilities, your projects have all developed strong partnerships with community structures and facilitated linkages between these community structures and the formal health sector. Can you discuss your partnerships with different community stakeholders and the effects that these have yielded on your projects?
Okay. This is a very interesting integration or linkage between the informal sector and the formal sector in managing health issues within our communities. In that, we are having change agents. These are community health workers, community health committees. We have the CBOs. We have community-based organizations that we work around together with. The main issue or the main strategy that is being used here is capacity building of the local structures. These are the agents, or this is the level that is bridging, because we are having the levels of health management that is running from level 2 to level 6. So you find that there is a gap to bridge the households and the formal levels, that is level 1, where we are having trained health workers. So you find that the CHW is collecting information that concerns to health issues. Then the information collected is being reported to the health facilities. Then the linkage continues up to the policy level, that is at the national level. Then you find the same is replicated, that should there be any policy that is supposed to reach the household, is also going through the same channel, where you find the link person between the CHW and the health sector is called community health extension worker, who supervises the CHWs and then feeds the formal health system. So this is how we work, and currently, as we are talking, we have even community based organizations that we've trained, and they are working hand in hand with the formal sector, that is ministries of health, Ministry of Health as per se, because we are now having Ministry of Public Health and Sanitation and Ministry of Medical Services. So this is how we work, and you find that the CBOs, the community-based organizations, we've trained them in various areas to the extent that now you find that they are running like we've sub-granted them in that we've given them a section of our objective, that is the objective 1 of our project, that is focusing onto the capacity building and running reporting and doing monitoring of activities at the very local level, that is household and within the community level. So this is in a nutshell how we run that section. Thank you.
Thanks, Charles.
Thank you. In our case, having recognized the importance of community partners, right from the beginning of our project implementation, we identified the core groups of partners in the community whom we shall be working with. Now, these groups include the community village leaders. In our setup, we have the village leaders and ward leaders. And these are the lower level of the government administrative system. That when it comes down to the village, we have the village chairman and the village executive officer. These are the recognized leaders who are there to oversee all the project activities in the village, who are there to report to the higher levels, the district commissioner of whatever progress is going on in the village. So having known the importance of this type of community leaders, we engaged them. We gave them 2 days training so that they should know what the project is after, what are the objectives of the project, and also we tasked them to oversee the community health workers implementation activities.
Dr. Mujungu, in addition to the village leaders, did you also work with religious leaders? Can you talk about your engagement with the religious communities?
Yes. Yeah, in addition to the community leaders, we also engaged the religious leaders. These are another key partner to work with. Religious leaders, they have people behind them, and they are very respected in the community. And therefore, we trained the religious leaders after we have developed the malaria ceremony guide training. We collaborated with the government to come up with the document, which will guide the religious leaders to sensitize their fellows on malaria issues. So we after we had the malaria ceremony guide, we trained the religious. We gave them 1 day, 1 week training, so that they are aware of the various issues pertaining to malaria, various malaria prevention messages. And then they went on using these ceremony guide training, ceremony guides to train and sensitize their members in various religious congregations, maybe in Sunday schools or in wedding, in funerals. So through that way, religious leaders have been appreciating, and we saw things moving, because on average, per month, we had 100 religious congregations being done by religious leaders. So it's another key partner whom actually helped the project to move forward. We also made use of the community health workers. As I said before, these were the cornerstone of our project. We gave them training, and then we tasked them to go house to house to visitation to provide malaria prevention messages, but also to attend various community meetings which are conducted in the village. And in those meetings, they provided, they used to provide malaria prevention messages under the supervision of village leaders. So, and another strong stakeholder, community stakeholders, were the primary school health teachers, being recognizing the importance of primary school health teachers, that they are also respected in the village, that they are learned person who actually they are dependable on when it comes to issues of malaria and other scientific issues. So we train them on malaria prevention issues, and in turn they trained the pupils, but also they went to train the village development committee members, because they are the members in the village development committee members. It is a committee of 25 people who oversees the village activities. So in that way, we found that we had a link between the community and the higher levels of health provision services. Thank you.
Great, thanks. So you mentioned kind of a new community partner that's now of greater interest, which is school teachers and school children. And I was hoping that Evaristo could talk a little bit about that, since that was really what ADPP Angola's project was kind of formed around.
Okay, ADPP Angola has a long-term agreement with the Ministry of Education to train teachers for rural areas. It's experience from 25 years. And also we have agreement with the Ministry of Health about the reinforcement of community health. Therefore, based on this agreement, we have made this agreement on the provincial level to make sure that the province, they can include malaria as an extra curriculum. And then we made the agreements on the municipal level with education and also with the health clinics. And then also we made agreement with the private sector, like oil company who provided the mosquito nets to the projects, and also PSCI. So in this structure, we have using the school, as I said, as a base. And as we have already this agreement with the Ministry of Education, it was easy for us to work in the schools in the communities, because we have already teachers in the communities who, besides of being a teacher, as a normal teacher, also they do community work. So we combine these two activities, and then they are respected in the communities. They have a connection with the local authority, with SOBAs, and also they are good connection with the health clinic. You can imagine that after all, one of the problems that we have in Angola is the lack of human resource with the capacities and also infrastructure. So to have this kind of teacher who can be a good teacher in the classroom and also can be a good community activist who can promote malaria awareness, it's very important for province like where we're working. Then we have, to secure the sustainability of the projects, we have trained the clubs for teachers, club for students, what we call patrols. So those clubs, they will continue to connect with the LC Center to continue with the campaigns. Just to give you one example, right now Angola has a commitment for universal coverage of mosquito nets. We are going to distribute about 10 million mosquito nets. It means 1 per 2 person. So in the province where we've been working, our patrols, our teachers, also they are part of the campaign to secure that people, they will get mosquito nets and also they will use them.
Thanks. So malaria in pregnancy remains a challenge, and most countries have not made significant progress in this area. How did your projects address malaria in pregnancy, and what best practices or lessons learned can you share with us?
Okay, thank you very much. Malaria in pregnancy remains a very big challenge, as you have said, because it tends to be more common, more severe, and more fatal. And in most cases, it's also challenging to treat for the physicians. So in our project, we had one of our key objectives to prevent malaria in pregnancy through increasing IPT2 uptake, especially IPT2. So what we did, in our country, we have the volunteer health workers that we call village health teams. These are community volunteers that are selected by the communities themselves and trained by either the Ministry of Health or an implementing partner who intends to use them. So for us, we pick the female